Okay. Okay. Thank you. Good morning and welcome to this public briefing on the Standing Committee on Social Development. My name is Jane Way-Allen Armstrong, MLA for Mofi and from Klucha Region and Chair of the Standing Committee on Social Development. So now I will now ask the member in the House here in the, to introduce themselves for the record, followed by those who are online. Starting with
Kira Testard, member for Range Lake.
Julian Morse, I'm the member for Frame Lake.
Good morning. I'm Shauna Morgan, member for Yellowknife North.
Good morning. I'm Cheryl Yakla. I am a member for the Dutcho.
Thank you, members. Today we will receive a briefing on healthcare sustainability and accountability with the NWT Medical Association. Please note this meeting is being live streamed to the Assembly social media channel. I would like to remind all members and witnesses to direct all questions and comments to myself and to wait to be recognized before speaking to help us have a smooth meeting. I will now pass it over to our presenters. Please introduce yourself and proceed with your presentation.
Great, thank you. I'm Dr. Stacu. I'm an orthopedic surgeon in Yellowknife here.
I'm Dr. Cassandra Mooney. I'm a primary care physician here in Yellowknife.
Hi, I'm Dr. Courtney Howard. I'm an emergency physician and president of the Northwest Territories Medical Association.
Hi, my name is William Gagnon. I'm the executive director of the Northwest Territories Medical Association.
Great. Hi, so I'll just start off and then I'll hand over to our physicians who are in the room. So thank you for having us at your committee meeting and thank you for your interest in this issue. I know that we all share a desire to have good care in the territory, to be able to take good care of people and to make sure that the systems that we're working in are efficient, running well, and are modern in a way that allows us to make the best use of everybody's resources. So we are speaking on behalf of the Northwest Territories Medical Association, which is our official advocacy body and also is the bargaining body that interacts with the Department of Finance to get the contract for physicians in the NWT. We will represent our experiences on the front lines, of course, without betraying patient confidentiality, and do so within the structure of the official advocacy body. Next slide, please. So there's so much we can talk about, and we hope to have a lot of wonderful questions from you. We did, though, want to focus the discussion a little bit on the elements that we see as critical for us to be able to continue to have a healthy physician workforce in the territory in a way that will allow us to provide the health care that we know that people need. So Will and I are in Toronto right now. We've just come from a meeting convened by the Canadian Medical Association for all of the presidents and CEOs of the provincial and territorial medical associations. So we're freshly briefed really on the situation around the country. And we have had a lot of chats with other medical associations about moving to an interest-based negotiation model. And we had a lovely coffee yesterday with the team from Prince Edward Island and really learned from them how much that approach to negotiations allowed them to really build relationships with their governmental partners to make sure that issues that actually weren't to do with financial remuneration were addressed. It sounds like they, in a way, just showed up on their end, having already surveyed their membership about all of the things that they loved about working there, all of the things that were not working, and met the employer having done the same thing. And then they were able to actually work through a lot of the challenges to the healthcare system in terms of the way primary care is structured, in terms of the way referral patterns work, in terms of approach to virtual care, along the way to their eventual contract. to the point where they're now in an implementation phase, and they're starting to see real changes in the way they practice, and really a lasting improved relationship compared to the way we currently do our contract, where we sort of send letters from lawyers back and forth. This allowed people to sit down at the table, as they said, look into the whites of one another's eyes, get to know one another as people, and build that trust that we know is really required for change. And I think we can all agree that change is required in the healthcare system now. And we see that this could be one way for us to build those relationships and the structures to give ourselves a chance to have those conversations. In our contract negotiation rotation, we actually need to decide quite soon whether this is a way forward for us. So we have approached the Northwest Territories Health and Social Services. We've spoken with Kim Riles. We've spoken with Claudia Kraft. They have approached the Department of Finance on our behalf, and we will also be making outreach. But we know that if we have the support of other members of the Legislative Assembly, that would be really, really helpful. So happy to take any questions about that as we go today as well. Our second thing that we wanted to mention is that there's kind of no getting around the fact that we do need to fund healthcare more. I'm an emergency physician, and there have been a lot of times over the last couple of months and a year where when I finish my shift, I'm handing over to a doctor who has just flown up from, say, Toronto or Vancouver. They've spent an entire day on the plane that we've paid for, not only the travel, but their time. They're going to be working for 1 or 2 days. And so when they're working as a locum, we also provide them with housing and as well as often a car. And then they fly all the way home. Again, we're paying for their time and their travel. And they say that, like, we're very lucky that they're coming to fill our gaps, but at the same time, it's incredibly inefficient from a healthcare expenditure standpoint. And that's partly because we're having trouble keeping our permanent staff. And there's various reasons for that. Partly, there's no longer really a premium in the contract to encourage people to, for the most part, leave their families in the South, come and signed on as contract positions in the North. I know that when I signed on 15 years ago, we were going to make a little bit more in the NWT, and that was one way that we could sort of justify to ourselves coming up there with all the student debt that we had as a result of having finished medical training in Canada. That no longer really exists. And so it doesn't exist for contract positions, and it doesn't really exist for locum positions as well. So we're at really a crisis point where we're having trouble keeping primary care staff. And we have almost half of the emergency room shifts not covered over the next about 5 months. So there's real danger that we won't be able to keep the emergency room open over the next few months if there's not a change. So we wanted to really flag that for you. It's no longer at the point where the people who live in town can just volunteer for more shifts. We just don't have enough people in town to cover those shifts. So we need to change the incentive structure. And in terms of other things that we could use to make people's lives better now, there were a lot of talks. We had an entire presentation on virtual care and artificial intelligence. So in many jurisdictions, they're actually now, New Brunswick, for instance, actually paid for a license for a virtual care, a digital AI voice transcription device for all of its members. So they're just talking into their phone, having it transcribe the note, and then putting that into the patient chart. What we're hearing from people is that this is buying them hours back every day. So they get to have lunch, they get to go home from clinic at a reasonable hour and see their kids. And those are the types of things where if we can improve the lives of the physicians who are in town now, who are in the territory now, they are more likely to stay while we sort out the rest of the system's issues. So sometimes there are barriers associated with privacy in order that make it difficult for us to roll those out. And we need to make sure that we're really using all of the tools at our disposal to safely but efficiently implement those new technologies as they come out. And we could really appreciate your help in moving those things along quickly. So I will stop there, and I will hand over to our my colleagues in town. Another real opportunity we have now is to also invite other people to the territory through improved national licensure programs, taking advantage of the physician outflow from the U.S. The Trump administration is not being very helpful to health and sciences, and many physicians are seeking refuge in Canada. So if we can decrease legislative barriers to their ability to practice in the Northwest Territories as well, that could be a real opportunity for us. So I think, is it Dr. Cassie Mooney who's going to speak next? I'll hand over to Dr. Mooney and Dr. Stacku.
Please proceed.
Thanks. So I'll talk next. I'm going to start with a little bit about who we are as physicians in NWT. So when I first moved up here, I was really drawn to the community, the outdoor aspects. So there's a lot of things to draw us here. Like the practice is very interesting. I like dealing with the patients, the variety of care. Also, another big thing that draws people here and who want to stay here is that we're all very interested in the relational aspect of medicine. So our colleagues are our friends. And our colleagues here are really a remarkable bunch. So, Dr. Howard, she's a renowned leader in climate health. We have a president-elect for the College of Family Doctors. Dr. Wong was president of Canadian Pediatric Society. Dr. Affleck was a recipient of the Order of Canada, and it goes on. So the work here draws really passionate and dedicated practitioners. But as we're going to elaborate, is we're at risk of losing these physicians, especially the ones who care the most and are the most passionate. So this slide is important to really appreciate why we're in a healthcare crisis. So in the last 20 years, the NWT population has only marginally increased. What has changed drastically is our age demographics. The elderly population has increased dramatically. In 10 years, the population over 60 has increased 1.6 times. Population over 65, 1.7 times. Population over 70 is almost doubled at 1.8 times. That is in just 10 years. In 20 years, the population has more than doubled, 2.6-fold increase. An elderly population has more healthcare needs and they're more complex. So the demand for healthcare in NWT is skyrocketing. And this is what I see in my practice. When I first started, I'd see 1 or 2, sometimes no hip fractures a month. Hip fracture is an injury that's common in elderly people. Now, hip fractures are common weekly, sometimes several a week. And these patients require urgent surgery, and they have prolonged admissions afterwards. However, operating room nursing levels and anesthesia staffing have not increased in 20 years. Increased healthcare demands are not only stressing surgical services, but even more drastically primary care emergency departments, and it's forcing Stanton Hospital to frequently be in code gridlock with no staffed beds available. So the objective today is that the NWT wants to openly present urgent concerns about the risk to patient care caused by critical staffing challenges and barriers to cost-effective, high-quality patient care. All right. Oops. Oh, shoot. Okay, shoot. I may have, well, was going to show you a slide with, maybe if you can flick through and see if it pulls up, where we're comparing healthcare expenditures. And in it, just quickly, so in 5 years, spending for resident physicians has increased 2%. There's been a 29% increase in medical travel and a 107% increase in locum physician costs. Yeah, 26. Oh, no, that's not it. Yeah, that guy. I think the big takeaway from the graph is just essentially that medical travel costs, locum physician costs are dramatically increasing, yet local physician expenditures has not increased. What I want to bring forward is that not funding front lines adequately actually will be even more costly. So this was borne out a few years ago when on obstetrics, and I did intend that pun, but the unit had to close for weeks. There was acute staffing concerns, and this culminated, there was red flags for months leading up to that closure, and these concerns were urgently addressed. And this was a very costly situation. Patients had to be transferred to Edmonton to have their babies, and not only was it costly, it's not good patient care, it's not patient-centric. I'm worried that they're going to have an even worse situation this summer and emerge, as Dr. Howard was mentioning. There's critical shortages in the ER doc coverage. To address this urgent concern, that's, we're talking next month, we need to pay ER shifts that are in keeping with what's being offered around the country. We're no longer competitive for these similar postings elsewhere in the country. And the big difference between those other places and here is that we don't have another emergency a couple hours away. This ER can't close. But without decisive action, reduced services, I worry, is very much a possibility. So not only immediate increase in locum pay to attract physicians to keep the ER open this summer, it's a necessary solution, or else we're going to be putting patients at risk, and this will ultimately cost more. A strong locum program for ER coverage is necessary and important to allow our local physicians to have time off so we can maintain a healthy workforce and retain those physicians. ER care is episodic and lends well to locum coverage, but familiarity with the system is necessary to be cost efficient. So to increase ER locum coverage to be competitive with Southern contracts, but it needs to be structured to reward long-term and regular locums. And this type of model is already used in Nunavut. Practitioners who are familiar with the system provide better care that is more cost efficient, and also patients value continuity of care. So outside of a Band-Aid solution for ER, which is at risk of service reduction, the priority needs to be on local staff. And ultimately, this requires funding front lines appropriately. Funding bureaucracy will not address the fundamental failures to fund the front lines. And I want to be clear, this is actually not just about physicians. To have an effective healthcare system, there are many healthcare staff whose work is critical. Lack of support staff, such as program assistants and hospital clerks, is underappreciated as to providing the role in safe, cost-efficient, high-quality care. There's a lack of redundancy built into these positions. So when someone is on leave, or, for example, Emerge, which is open every day, but is only funded to have a clerk 5 days a week, certain critical steps in the system grind to a halt, and this affects patient care. If we truly care about mental health, the psychiatrists need to have a dedicated program assistant. This week, the psychiatrist is calling multiple people trying to fix her computer rather than seeing patients. She does not have a program assistant. The whole program does not have a program assistant funded. She is doing clinic admin work of booking patients into clinic. This is a factor that people get frustrated with and don't want to work here. There's no program assistant to call patients to ensure the highest risk, most vulnerable patients are accessing the follow-up care they need. Yet we are telling nurses to screen patients for suicide before colonoscopy, which has no evidence and is actually a highly inappropriate time to be asking those questions. We're focusing on inefficient, non-evidence-based factors and not dealing with very common sense funding that needs to be brought forward. Another one that comes up a lot is lack of flexibility in scheduling and part-time positions for nursing. It forces them out of the front lines. I would like to know how many nurses currently work in non-frontline jobs. The system is very top-heavy and the foundation is falling apart. Flexibility and incentives are needed to bring people back to frontline positions. Staffing levels need to be increased to make the job rewarding rather than distressing. Ultimately, investing in the people who are delivering healthcare, from clerks to physios to rad techs, is the most efficient way to cut down locum costs, cut down on medical travel, and create a system that is delivering culturally sensitive and high-quality care. And Dr. Mooney will go on.
Yes. Yeah.
Thank you. I'm going to talk more about like the vacancy rates. The slide that we were going to hopefully share shows that we have a 49% vacancy rate in primary care physicians in the NWT and a 42% vacancy rate in specialist physicians in the NWT. The 2020 physician workforce plan laid out exactly how many physicians should be allocated to all communities and regions in the NWT for adequate culturally appropriate care. We are nowhere near this. On the surface, it may look like we are adequately staffed. However, the reality is that staffing is increasingly thin and fragile. We are so short-staffed that even if you denied every physician's leave for a month, we could still not fill our own schedules. This leaves no buffer in the system to absorb unexpected events. For example, if a physician is unavailable on any specific day for any reason, family, medical, colleagues then get shifted at last minute to have a new assignment for that day. And unfortunately, when you reallocate resources at such a last minute, the areas that get most impacted by this are a physician's visit to a community. So another example is if we have a local specialist physician, let's say, for example, we have no orthopedic surgeon in town for that day. We have a patient who comes in from out of Yellowknife with a hip fracture. They get to Yellowknife being told that that's where they're going to be. Their family is not on their medevac flight. They have to come on their own flight. Their last stop is Yellowknife. But now we do not have a specialist in Yellowknife to take care of this hip fracture. We have to now reallocate all of that funding to medical travel down to Edmonton to a new specialist. Their family gets to Yellowknife. Their loved one is no longer in Yellowknife. They too now have to get a flight to to Edmonton. So ultimately, this one day of vacation is costing the NWT tens of thousands of dollars. This slide speaks to a survey that the NWTMA did at the end of last year to gauge physician satisfaction in the workplace and to see what areas we as physicians would like to see improved on. The decisions here show that 63.9% of colleagues have considered leaving in the past year, and 11% actually have ended their contracts. These decisions are largely influenced by major disruptions to relationships and workflow, and the insufficient physician-led innovations on the front lines. We currently have a top-down approach to leadership, so frontline workers are not part of any decisions being made for healthcare delivery. A large part of why physicians are leaving does unfortunately have to do with the recent rearrangement of primary care. Instead of implementing previous strategies, leadership is trying to redefine the goals that we already had in place. It's no surprise that every physician in the NWT would like to see care being moved towards an integrative team-based care. However, just making a team doesn't check the box. You have to actually staff that team that patients are now supposed to be a part of. An example of this is that a physician who worked here for 20 plus years, raised their family in town, has multiple friends, and was an integral part of the street outreach program in Yellowknife. Without being asked, how does this system work? How can we make this team better? The whole program was totally ripped from underneath them, and they were assigned to a new area. Physicians have repeatedly brought up the fact that this is an unsafe change and that we can no longer provide safe and timely care to our patients, but we keep getting met with a lack of empathy or acknowledgement for the responsibility of these changes. In this specific case, this physician felt that they could no longer provide safe and sustainable care and that they were being disrespected on the front lines and therefore chose to end their contract completely. The glaring vacancy in medical director roles has further increased the gap between frontline and leadership, and this is leading to significant mistrust between both levels. Given the nationwide shortage of healthcare professionals, we must start caring for providers who provide care in the NWT. So, with all of this information, this is the final key pieces that were brought on by the survey that we did. Local physicians, with people leaving, it means that the one physician who's left behind is being stretched thinner and thinner. For example, primary care is also not just responsible for the clinic, it is also responsible for oncology services, methadone treatment programs, correctional services, anesthesia, and helping out in the ER, and that's not an exhaustive list. But funding allocation has not matched the increase in these service provisions. Another way to help physicians would be to reduce the unnecessary administration burden. That would allow physicians more face-to-face time for direct patient care. Examples of this could be the implementation of AI or e-consults. A very real example in our everyday lives at the moment is that our imaging system for reading x-rays and CTs and ultrasounds was recently updated with the hope that we would be able to share these images with our colleagues down south so that when a patient is transferred to Alberta, the physician can actually see those images. The reality is that we're more than 6 months into this program, and that hasn't changed. So when a patient has a CT scan done in Yellowknife, a Yellowknife physician is then spending time on the phone with a specialist down south, reading out the report out loud without any imaging being sent to the specialist. Then we have to put the images on a CD to give to the patient to take with them to Edmonton. When they get to Edmonton, they can't read our CDs. So they're just getting a whole new CT scan anyway. So now we're costing the healthcare system double. So there's a lot of examples in our presentation, but in conclusion, the NWTMA is respectfully asking you, the Standing Committee on Social Development, to one, publicly express support for the pursuit of interest-based negotiations between the Health Authority, the Department, and the NWTMA, to advocate for the reallocation of funding to the front lines in order to provide each community with adequate culturally appropriate care close to home, and to expedite the execution of locum contracts for this summer 2025. And thirdly, to strongly encourage the critical review of the interpretation of the current Health Information Act to eliminate the bureaucratic barriers to modern healthcare. Thank you.
Thank you. Thank you for the presentation. I will now ask the members if they have any questions. Okay. Okay. Mr. Testard.
Thank you, Madam Chair. And thank you very much for the presentation. There's so many issues here that we have been, you'll be pleased to know we are very aware of, at least at the level of the Standing Committee, which is why we have initiated a study to look into healthcare sustainability that is independent of the work that the government is doing with their, and we're having a public briefing on that later. But hearing from frontline workers, we know the situation is dire, whether it's doctors, whether it's nurses, whether it's allied health professionals. And clearly, we need to make changes. We've needed to make changes for a year now. They're still unmade. And I feel that we are making the same kind of top-level management decisions to fix the healthcare system that you're warning us against. So turning to a very practical concern you've raised, which is a very serious one about the potential threats to closing the ER, as we saw with obstetrics. I was told by frontline workers that it was a very similar situation last year, and many people felt the ER was going to close over the summer last year. Thankfully, it didn't. So is the government playing, or is healthcare management, the people in charge of the system, are they playing chicken with the ER and instead of actually trying to fix it? Because it sounds like everyone is sounding the alarm and nothing's being done. Thank you, Madam Chair.
So I can, okay.
I'd be
Please
happy to
proceed.
answer that question as an emergency physician, if that's okay. Thanks for the question. So, as we said, the workforce shortage is international, national, and local. And what that means is that we're in a market of the entire country when it comes to locums. So night shifts, for instance, in some places on Vancouver Island are paying fully double what we're paying. I've been asking locums who have been coming recently if they're taking a pay cut. I still haven't found one from any part of Canada who doesn't say that they're actually making less in the NWT than they're making at home. They come anyway because they like the North. They enjoy working in our ER, in our hospital system. They enjoy interacting with a strong Indigenous community. These are the reasons why they're still coming. However, they're not coming in great enough numbers. What happened last year was that kind of at the last minute, there was an increase in salary for the locums to try to entice people in. The problem is that, that in isolation may keep, and last year did keep, the Emerge from closing, although we were still asked to work 12-hour shifts in some cases. So generally speaking, there are 4 emergency shifts per day. That's reasonably safe coverage. On those days, there were only 2. So instead of having 4 docs with 1 8-hour period of overlap, there was single coverage for 12 hours. We have a busy, complex emergency room where we actually field calls from all over the territory. The cognitive load of that job over 12 hours, it's not safe. There's evidence that emergency physicians tend to see the most patients, be the sharpest for about 6 hours. It's accepted to do it for 8, but in a busy department like we've got, 12-hour shifts, especially more than 1 in a row, it's not, I don't consider that safe care. And especially when it means that you're actually down an entire 8 hours of a second double coverage physician. So we had extra pay. It came in at the last minute. Would have been far better if it had come in earlier, because by the time it came in, even last year, most docs in the country had already booked their shifts for the summer. What we're seeing now is way more empty spots, fully half. And some of them are in May. There's a weekend in May where we've only got 1 physician currently scheduled for most of the days. So we have no idea, genuinely, we have no idea how we're going to keep the doors of the emergency department open. As you know, the emergency department is the beating heart of the entire northern system. We hear sometimes on the news that, an emergency department near where I am right now in Ontario may close, but people can just go to the next town and seek emergency care there. It would be a disaster for the northern healthcare system, for the emergency department to close for even 1 day. But I don't know, with our current situation, how we're going to stop that from happening over the summer. So we need some kind of a similar incentive to be put forward for an increased amount of pay for the locum physicians for this summer, recognizing that that is only a stopgap, and really we need to be creating longer-term incentive structures for contract-based physicians to keep people in the north for good.
Okay. Thank you, Mr. Tister. Do you have a follow-up question?
Yes, thank you, and thank you to Dr. Howard for that. Further to this line of questioning, you mentioned that the locum contracting in Nunavik would be sufficient to meet Stanton's needs, or something similar to how it's set up. Can you elaborate a bit more on that? Oh, and on the matter of that last-minute pay, my mind goes back to the COVID pandemic and how we were equally late to get market supplements out the door. We were behind Yukon and Nunavut, so by the time they actually implemented it, those jurisdictions had already increased their labor market supplements. So this is, again, a persistent pattern of catch-up and last-minute decision-making instead of proactive planning around decisions that we have been warning against for quite some time. But on to the issue of this potential new locum contract. Is there a template in the Nunavik hospital that we could look at to model one for Stanton? Thank you.
Okay. Dr. Howard?
That's a good question. I don't know about the contract in Nunavik. We've heard that there is a locum contract in development, which is aiming to, for instance, I'm working as a locum right now for the reason that I do a lot of other work, and because we're not able to grant people leave in a reliable way, I can't maintain my commitments to my other professional work and be on contract in the NWT. And I still live here. Like, I still live in the Northwest Territories. My husband's a physician. But to just give you a sense of how unworkable it is right now to be on contract in the North as a doc, if you have any other kind of, there's so little flexibility. So we understand now that there is a locum contract in develop that is designed to encourage longer term locums and recurring locums. And I think that is a great idea. It will provide more consistency, as Dr. Stacky was mentioning, people who know the system better. So we just need that to get out the door as fast as possible. So we hear that there's things in development. They need to go out yesterday.
Okay. I do, since nobody has any question at this time, but I do have a question. I do understand, about the staffing shortages, because in one of our Clutha communities, we had paramedics team, and I know it was really it was a time consuming. We understand about the shortage, because I believe they were in contact with the Stanton medical, the doctors, and it was a lot of people had a concern about that, So I'm sure it's not just in our community, but in other community as well, in other small communities in the Northwest Territories. So, but it is good if we have at least one or two. The people do feel as long as there's a healthcare professional in town, in the community, it's reassuring. But if there's none, it's a major concern. So, but and I believe you did mention about AI. How effective are they for prescriptions? And I just want to know, how effective are they?
I can answer that. So I think the biggest benefit of AI right now is scribing capabilities, and that's what's offloading the paperwork. So physicians like to see patients and like to be in the room with patients. Courtney might know the stats, just being through the CMA, but a lot of my day is sitting in front of a computer, writing up reports, answering messages, and not actually doing what I think is the important part of my job. So every consult I see, I have to do a dictation or some sort of report to document, which is very important. And AI technology has now allowed scribing capabilities, so that can eliminate a substantial amount of the hours, mundane and less enjoyable tasks. Physicians I know elsewhere, orthopedic surgeons are using it are very happy with it. So it will take off some of that paperwork burden on physicians and make their jobs more enjoyable. And also, I believe patients value us seeing them rather than sitting in an office doing paperwork.
Okay, Dr. Mooney? Yes.
Thank you. I think another, specifically speaking to communities, and something that we have brought forward in the workforce plan and repetitively in documents that were shared last year with leadership, is the consideration of using AI as a way to have a physician for each community at all times. So if a physician came to visit that community, let's, for example, say it was 3 days a month and they were physically in the community, for the rest of that month, they would be available virtually at like every day of the week for that specific community. This doesn't need to be, it doesn't need to be a physician who's located in the NWT either. If we could decrease the barriers to AI and virtual care across the country, that physician could be a locum physician or somebody who doesn't permanently live in Yellowknife who visited that community, but the rest of the time was on call or virtually available for that community, taking away that huge barrier of a paramedic having to phone the ER. Instead, there would be a physician directly available for that specific community. And I think AI and e-consults and virtual care is a way that we could really fill that gap for the community specifically.
Okay, thank you. Thank you for the information. Now we'll go back to Mr. Testart.
Thank you. And to that point, Madam Chair, the pan-national licensing that we've often heard about, do our witnesses today have any guide or advice on where that's at as a national effort and how we can assist the process, or how we can encourage the government to assist that process? Because I think it's a crucial step to bringing more or reducing those barriers to getting physicians and other healthcare practitioners into the Northwest Territories. Thank you, Madam Chair.
Okay. Thank you, Mr. Testart. Dr. Howard or Dr. Statue? Oh, okay, Dr. Howard.
Sure. So this is certainly a priority for the Canadian Medical Association and all the provincial and territorial medical associations that we were meeting with this week here in Toronto. I understand that this has actually been put in all of the different parties' election platforms. So we anticipate, no matter who wins the election next week, that this will be something that the government of the day will be looking to implement. We already have regional solutions. So we've seen that the maritime provinces have made it possible for docs to move in between their jurisdictions. It's working really well. Apparently, everyone's very happy with it. So we think that there's the opportunity to start to scale that. So this would be a place where the health minister, when interacting with their other provincial colleagues, could be really making sure that the NWT is speaking strongly in favor of it. Again, there's also opportunities, we're hoping, to accelerate licensure for physicians from the US who are on their way north. So this would just be a situation where when the opportunity presents itself, as I suspect it will, that we need to move quickly as those opportunities come up, so that we're part of the conversation. We're helping to lead the conversation instead of being, on the more lagging end of it.
Thank you. Thank you. Now I will go to MLA Morgan.
Thank you, Madam Chair. Thank you so much for taking the time to be here. I know you're all busy. My first question is, you've outlined for us a number of alarming problems within the system, and you've also described how frustrated many physicians are and many desiring to leave. And so it seems that even though you're making many suggestions, you have many ideas as to how things can be improved within the system, there's many positive aspects of working with colleagues, people are passionate, there appears to be like a breakdown in the system where like these different problems you're describing and the various ideas you have to solve them, there doesn't seem to be sort of productive and free communication between the frontline practitioners and people making decisions. That's what I'm hearing. Can you help us understand that breakdown in terms of, some of the examples that you've given? So the danger of the ER closing. Are the decision makers above you aware of this? Are they telling you what they're doing about it? Are you aware of any strategies or plans? Is the responses that you're getting, okay, we're working on it, don't worry, we have a solution? Or is your impression that people are just not even aware, or that they don't see any solutions? Like I'm trying to understand the back and forth, or the conversations, or the breakdown between the problems you're seeing on the ground and the disconnect in terms of the responses coming from decision makers to the various problems, big and small. but even small problems add up. I mean, you've mentioned things that you see on the ground every day that just don't make sense or inefficient or, waste of someone's time. It's a protocol that's not evidence-based, or I assume you're probably communicating this to decision makers or administrators. So what's happening there? Why aren't these things being addressed, in your opinion? Thank you.
Dr. Stetcher?
Yeah, so I think, 7 years ago when we amalgamated the health regions, we lost all regional, local structure. So a common example I use is a normal hospital has several physician leaders, such as I'm a surgeon, so head of surgery is a common position. We don't have that. There's no one who can kind of deal with on the ground small, simple issues. So very small, simple issues always have to escalate to a territorial level, and there's very few decision makers. There are then complex problems like getting emerge, locum pay to match down south. That's a hard problem, and I do believe the leaders are aware of the problem, but I don't feel reassured that the urgency is there. So what I think frustrates me personally the most often is when there's very simple things that should be dealt locally that we do not have the power to do. So whether it be, a physician leader or even the CEO, everything has to go up to the next level. And then decisions are made far removed from the front lines. Example would be, just new forms coming in and new policies coming in that are illogical and waste people's times. And those are the daily frustrations that get people really annoyed. For example, a nurse just told me another form came to them to fill out, and she's like, I chart this in 3 places already. Why do I have to do this on a new form? We are still doing COVID screening questionnaires and pre-op. That no one seems to have the power in the hospital to say, at pre-op, we don't have to screen for COVID because we don't do anything different. Like it's the pandemic measures are over. We can't get rid of that piece of paper. No one seems to have the power to do that. So I find like little things like that in my day-to-day very frustrating. But then there are for sure hard problems. The solutions for hard problems, another example I worry, we always talk about trying to batch medical travel. So a person's not coming for an ortho consult 1 week and then fly home, come back 3 days later for an obstetric consult and then fly back home and then go back for CT. And so there's always been talk about how to fix that. And I worry they will create a position that's not in the hospital and just have someone who is not familiar with the system to try to fix that problem, when what we need is probably more clerks who are then have the time to talk with the clerk that's just across, the room from them and try to batch things together. We have the capabilities to do that if we, fund the front lines appropriately.
Okay. MLA Morgan, do you have a follow-up question?
Yeah, thank you for that. And thanks for sharing more of those insights. When it comes to the primary care reform, and Dr. Mooney spoke a bit about the team-based care, which I understand from you is widely supported amongst physicians. You can clarify if I'm wrong. But again, I had heard from many physicians about frustrations about the way that the reform was being done, the way teams were being rearranged. And yet we've often heard from the health minister that all of these changes were necessary, and change is hard, and sometimes people don't like change, but people will just kind of get used to it, and this is just a matter of people needing to get used to the fact that change needs to happen. But I wonder if you can explain from your perspective, being on the ground during some of those changes and reshuffles and rearrangements, how were physicians involved or, not involved in, 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 in being able to help make those changes the best they could be. So as things are being changed, to make sure that they work best for patients, for the system, and for physicians. Can you describe like your attempts to work with decision makers during those rearrangements, and how you might see that it could be done better in those cases where perhaps reform and change does need to happen? Thank you.
Dr. Mooney?
Yes, thank you for the question. The change for the primary care system came without any input from any of the physicians. It was a decision made by leadership. We were told one day that it was happening, and 2 weeks later it happened. And that was frustrating to physicians because we actually had things that were working really well, but instead of trying to keep those implemented, we felt as if we weren't really asked. We weren't asked for our input. For example, the example I gave about the street outreach program, there are different physicians involved in that program. So it would seem that a step that could have made the move easier would be to put those physicians on the same team, so that team is now responsible for street outreach. That integrates team-based care into that population. But instead of doing that, they were all dispersed amongst other teams. Then stretching things thinner, it's very difficult now to coordinate vacation time amongst colleagues because somebody has to be around to do that work, but we're not in the same group to make those decisions. And unfortunately, what happened with the move is that where we used to have teams of like 2 or 3 physicians, or 2 physicians and a nurse practitioner, or vice versa, it was easier to coordinate between each other. And also, when somebody's not available, a physician is then covering for their colleague. So you're covering for 2 other people. Now we're in bigger teams, so on any given day, I'm covering for 4 other practitioners, which means that 4 hours of my day is paperwork for patients that I've never actually seen. So I'm not actually seeing patients because now I'm covering for 4 people. And we've tried to bring forward this concern about the administration burden and how these changes are impacting that. And in the beginning, it didn't really seem that leadership was aware of how this was working. Now, the reality is that within our own teams, physicians are doing things amongst ourselves to make it work. Like, we've created physician systems that are working amongst ourselves, and we talk amongst ourselves, but there's no indication that this is a system-wide change, or that anybody else is realizing that we've asked to do it this way, we're doing it this way, it's working, but it's not coming from the system down. And it's hard when I think physicians are frustrated because we've tried to bring these issues forward, but nothing ever seems to happen. And with primary care reform, part of the concern on the front lines is that where are the physicians in this? Like, primary care reform is being made by a team who arguably never worked in healthcare. Like, where are the physicians? Where's the nurse practitioner? Where's the community health nurse on that primary care reform team? The people who actually know the decisions that need to be made or that could work. And the leadership has correctly, they have implemented these teams to have meetings amongst us. Right now in primary care, there's a team that's doing administration work and how to streamline that, and then a team that was supposed to be helping with the allocating of patients to different teams and how do you staff those teams and what patients should go where. But the reality is, the team that's supposed to be doing the team-based care and allocation of patients to a team has met once in the last year. When we asked for more information to help us guide our decisions, we're repetitively met with roadblocks. And it sounds like the person that we are directly reporting to and asking for that information is also unable to get that information. So the roadblocks are coming from higher up, not from the physicians and the teams on the ground. And so that's where we're struggling with the whole process of primary care reform. Like, if we could include physicians and frontline staff in the decisions being made, things could potentially start happening quicker.
Okay, thank you. Now we'll go to Mr. MLA Morse.
Thank you. And thanks for the presentation. Yeah, I have to admit, I was kind of sitting here not really sure what to ask because unfortunately, not much of what you shared with us today is news to me. I mean, this is very similar to what the NWTMA has been saying for well over a year, certainly during the entire time I've been an MLA, and the problems are things that I was hearing about before I even ran. And you know, I think this committee has been taking those concerns quite seriously. MLAs have. I'm sure you've followed, you know, you may or may not have followed kind of what's been going on in the Legislative Assembly, but there's been motions related to problems in the healthcare system. Virtually everybody in this room has made numerous statements about it. So, like, we've been talking about it a lot. To get to the pointed question, I mean, one of the things that has happened in the recent past was, you know, I think due to a lot of this pressure, the governance system of the NWT, or sorry, of NTHSSA was changed significantly, where the board was removed and the public administrator was put in. And my hope was that would bring about kind of a better sense of urgency and also some motion towards change. So what I wanted to ask is, has the NWTMA felt that that there is at least some movement towards change? It is always frustrating how slowly things move in these big complex systems, and I can very much sense that frustration from the presenters. But is there movement towards change? Is there a sense of that? Or do we really just feel that we are still in the place that we were a year ago? Because that's what I'm hearing from you. And so at this point, I don't really have questions for you. It's more for the leadership of NTHSSA. Well, that's where I'm at. Thanks.
Dr. Moody?
Going to suggest Dr. Howard maybe
Okay,
take this question.
okay. Dr. Howard?
Sure. So we have had several meetings with the leadership of NTHSSA as well as Mr. Florazone. We see that he definitely feels that he has a task ahead of him. We see some urgency with it in his eyes and in his voice when he's speaking with us. We've asked for meetings monthly with that group, just citing the real urgency. The most recent communication we had was suggesting we do it quarterly instead. We're going to keep asking for monthly because we do believe it needs to, you know, when a patient's crashing, we check their vital signs more often. So that we can have a rapid reflex feedback loop between our actions and what we see. And we really think that we need the same here. I think, backing up a little bit, looking at what's happened in our medical community over the last 5 years, we had COVID, huge disruptor, a lot of psychosocial stressors for everybody. And then we had the wildfire-related evacuation. We've been having a lot of meetings here in Toronto as well. Really to help coordinate sustainable healthcare for the country in order to ensure, and I've said to many people, I don't want anyone else's neighbor to have to figure out how to evacuate an entire hospital on a couple of days' notice. You can imagine that when that happened, many people were learning very quickly, were having to, under the weight of huge responsibility, deliver for the population at a moment where we were not prepared. And that leads to asking people without having gone through what the structure of an emergency response plan ought to look like, to ask them to do things they wouldn't normally do, to at a moment where they were scared as well for their families. And you can see how that could very quickly lead to ruptured relationships. And ruptured relationships, we're all human. Every single person in the system is themselves a human as well, and dealt with that evacuation on a human level. And I think that some of the relationships that were strained during that time are leading to worse communication than we would otherwise have, to a lack of trust, to that feeling that, you don't want to go into that room because maybe it won't feel good in that room. So maybe you'll stay back in your office with the people who agree with you. And so this is one of the reasons why we're really hoping for this committee's support for interspace negotiations, because the last thing we want to do is negotiate our next contract, again, in separate rooms, sending our lawyers missives back and forth. And we want to sit down across the table from leadership and say, what's not working on your end? This is what's not working on our end. And what we've heard from, for instance, the Prince Edward Island Medical Association, they just started talking through challenges. This isn't working. Okay, how come it's not working on your side? What's the holdup for our ability to be able to institute artificial intelligence aided dictation? Who is it that you're talking to? This is what we would like to see in a program. And they would just go through it and solve those problems, put them up on the board, and move to the next problem. And then after problem solving, they eventually got to money. That's what we would like to see. And they found that by the time they got to money, they had a much better sense of the system they were building together. And then that was only a very small part of what they were doing. So we view this as an opportunity to rebuild some of those relationships through sheer time spent in one another's company, problem solving and finding solutions. So as we'd mentioned, we need to decide quite soon whether to move forward with interspace negotiations or to do the regular way that we have in the past done it. So any expressions of support that the community or the committee could have for that approach, or any questions the committee may have around that, would be very appreciated.
Mr. Morris, do you have a follow-up question?
Yeah, thank you. I guess, the follow-up would just be, what barriers are there to the NWTMA sitting down with leadership and working through these problems together exactly as you've described just now? That very much sounds to me like what needs to happen and what should have been happening years ago. So is it so difficult to organize a meeting or to organize a conference or whatever needs to be done to just kind of put everybody in a room and work through these problems? And I guess where I'm confused is, why does it need to center around contract negotiations? Is there some kind of glass barrier between you outside of those negotiations? I guess I'm just confused why, for lack of a better way of putting it, we can't just sit down and solve these problems. Everybody's aware of the problems that are there. It's become a big political issue for the minister, for the department. There's constantly news stories about it. MLA's squawking about it on the floor. It's very clear to everybody involved here, including, just patients, like people in the NWT, our constituents who we hear from constantly, nurses. Everybody knows that there's significant problems. So what is preventing us from, or I guess preventing you from simply sitting down with leadership and working through this? It's very puzzling and confusing to me why that's not happening, if it isn't.
Well, it's not because we haven't sent the meeting invites, Julian, is what I can tell you.
Dr. Stutcher, do you want to reply to that?
Yeah, I agree. I'm also confused why. As the NWTMA, we have had quite a few meetings with senior leadership. And every time, it seems like they get the problem. We sometimes have some very straightforward asks, what I think are cost-free changes that can help bring, because as I said, we really value relational aspect of medicine. People come up here because they want to know their colleagues. They want to, work with each other to build a better system, and we're not given that opportunity. And quite honestly, we did this survey recently. That's why people are leaving. They don't feel heard. They don't feel part of the process. And I personally have not seen much shift towards that. I think it has to do a bit with the fact that the decision makers are not sometimes even just physically co-located with the front lines, where you can have those hallway kind of discussions of like, what about this, and keep kind of bringing forward the issues and having them addressed. And the people making decisions, I think, lose sometimes the focus of what the real goal is. I often have to always bring it back to like it's patient care. We want to deliver high quality care, and having a healthy workforce that is well staffed, that is going to save money, because it often always seems to be about money. There's no money for this, no money for that. And I don't think it's funding a new program to look into something again is useful. We just need to have people on the front lines, and those people have to be able to voice their concerns and be part of the system to make it better.
Okay, thank you. Dr. Mooney, you want to add to that?
Yes, thank you, Chair. I think the direct answer to your question is right now, like, we don't have a medical director. Primary care doesn't have a medical director. So, like, the territorial medical director is filling both roles. That's unsustainable. No one should have to do both roles of medical director. The work is insurmountable. And so the people on the ground, we don't have that buffer. Like, as a new physician coming to Yellowknife, I shouldn't have to request a meeting with the COO to get anything done. Like, I need a medical director. I need somebody who's the buffer, who's going to speak on my behalf to take those things forward. And I think that's one of the very obvious barriers to why we can't sit down and have meetings. There's also recently been this notion that physicians are hard to work with, and that what we're trying to break that notion down and be like, we want to work with you, not against you. And so I think everyone is just very gun shy to have a meeting in the same room with each other, because it always seems to be heated. The other issue that has been brought forward is, what is the difference between the health authority and the department? Who makes what decision is something that we would really like to know as well. Because it feels like we have meetings with leadership, the health authority, but then they still have to take that to the Department of Health or to the finance minister. So there's all these extra layers, which is why we can't make the decision on the ground in a meeting together.
Okay, thank you. Thank you for the information. MLA Yakalaya, do you have a question?
Yes, I do. Thank you very much for your presentation. It was very eye-opening, I guess, for me. I live in the small communities, so and from what you're saying, because I know working for communities and participating in things that I worked mostly in mental health prior to becoming an MLA. I assist communities in development of things that have to do with thinking and lifestyle changes, making healthy lifestyle choices. And it's important. I understood when you said that where's the practitioners and where's the doctors in this healthcare reform? Because you need that type of leadership to be able to support a team of people that are doing what needs to happen for people, so healthcare is going good. And so that makes sense to me. Now, having said that, how is the services being affected in the small remote communities by this, what's happening here in Yellowknife? Thank you.
Dr. Mooney, do you want?
Thank you for that question. I am a physician who regularly goes out to communities and does community care. what we've noticed is that with the new changes in primary care, where someone is expected to be in Yellowknife at all times. And so a lot of the times, if there's nobody else available and I'm the only one here, I physically can't leave Yellowknife because the new reform says I have to be in Yellowknife. So then the community visit gets pushed further and further back. With the lack of physicians and physicians leaving, physicians who used to go out to those communities, like their positions haven't been refilled. And it's incredibly challenging to send a locum to a community who doesn't have the relationship with the population, hasn't done culturally appropriate training for our communities. And that creates an extra challenge on the contract physicians who are around as well. Part of team-based care and what we would like to see is the continuity of care. So, for example, I myself am a provider for Fort Resolution. I go every 2 weeks. But when I'm not there, I'm like virtually available to them at all times. And unfortunately, with our current structure in primary care and lack of resources, it's hard to get a physician that continuity. Like, it's not for a lack of people wanting to go. It's a fact that it's hard to go once every 6 months and not know what's going on. And so to try and juggle that around to a point where each, like for me, for instance, like I'm a zebra in this like situation. Like nobody else has what I have for Fort Resolution, but that's what we need for sustainability. But it's incredibly difficult to get that because we don't have the resources. And then part of this is for the community health nurses who are on the ground in the communities. We don't have a physician available to them for on-call. Like currently they have to call the emergency room to get a prescription for an antibiotic. Like these are the barriers that we're facing, and I think it all comes down to funding the frontline staff and funding more community health nurses, funding the physicians so that we can send a physician out there and have continuity of care.
Thank you. MLA Yakalaya, do you have a follow-up question?
Is there, yeah, it makes it life a little more challenging for people and in the communities, especially if they have to, because they don't get the care here, they don't get the care in some of the communities, and having to make that trek to come to Yellowknife or to Hay River, right? They will do that to make sure they get to get the care they need. Some people will do that, some people won't, and so that puts the people in the communities at risk of, puts their health at risk. That's what I wanted to mention. So thank you for your presentation. It's something really for me to think about, work with my colleagues and see what we come up with, and I really appreciate that. I appreciate your candid conversation for me to hear that. Thank you.
Thank you. Thank you. We have a hard stop at 10, so I believe MLA Testart has another question.
Thank you, Madam Chair. Yeah, I just wanted to follow up with the license sharing. So we're hearing a lot of, not just in this area, but in other areas of public policy where the Atlantic provinces have effectively pooled their resources together, from everything from their provincial nominee programs for immigration to now a license share for doctors. So is there would there be value in a regional license share model for the three northern territories, Yukon, Northwest Territories, and Nunavut for doctors? Or would it make more sense to look at some sort of partnership with Alberta, where we have a very integrated healthcare relationship? I'm just trying to say, like, I agree with Dr. Howard in that we need to take a leadership role in this because it's going to benefit us the greatest, and that's how you get attention on issues, when you can champion these things at interprovincial, like at federal, provincial, and territorial tables, in direct asks, the federal government. That kind of thing is not currently, I think, in our federal engagement strategy. So anyway, but those models look like there's a lot of good that we we could tap into potentially there, but I'm not sure how integrated we are with the Yukon and Nunavut systems. So if Dr. Howard has any thoughts on that, or any of the other witnesses. Thank you, Madam Chair.
So I'll go to Dr. Howard first. Yeah.
Thank you, Madam Chair, and thank you for the question. I think that would be really useful. We do provide a lot of services, particularly to Nunavut, so that would probably be the first place where this would be useful. You just reminded me, I actually have a reference letter I haven't done for an ENT surgeon who's about to go to a locum in Nunavut, who usually works in the north. But as he said, and as you know, they are also low on capacity in terms of the ability to generate licenses, et cetera. And so it would be, I'm sure, to their advantage as well as with the Yukon. It may be slightly more difficult with Alberta, but maybe not. We are well integrated with them, and I think both of those would be excellent ways to start the conversation. The more we sort of piece it together, the more it will start to look like a full puzzle by integrated national licensure, and I appreciate that initiative.
Okay. Thank you, Mr. Testard. MLA Testard, do you have a follow-up question?
Not on that topic, but if I can
Okay,
indulge
yes,
the chair, thank
please
you.
proceed.
So I think it was Dr. Mooney, you mentioned cost-free innovations, or someone mentioned cost-free, like things that have been pitched to the leadership in medical of ways we can improve healthcare delivery, take the workload off practitioners, all that stuff at no cost to government. Do you have some of the examples of that you can share today, or can you provide those to committee? Because it would be great to have kind of a list that we can go back to either the minister or the authority and just say, look, these things can be done. These are going to save time and money and improve everyone's lives. Get them done. Because I agree with Mr. Morris's comments. We have been talking about this for a very long time, but the action is not matching the talk. And the more we wait, the worse this problem gets. And some of the long-ranging plans we've seen are probably only going to start either impacting or being even proposed in the dying days of this government, and that's too late. So if it's not too much trouble, it'd be great to see or have some of those examples today, or see some of those examples that we can advocate for. Thank you.
Okay, Dr. Mooney?
Yes, thank you for the question. One of the biggest and what I feel could be the most obvious resources is the 2020 Physician Workforce Plan, where it was 4 years of research and collaboration to essentially say like what we could do. And I think the document is like 9 pages long of what could be done to help. And I think that could be a really great place to start. But another really good place to start would be just include the physicians in the decisions. Like, we could do this amongst ourselves if you would let us. It doesn't, but you have to include us. So.
Okay, Dr. Stacher?
Yeah, I think it was me who used that term, and it was in relation to the relational aspect of us with people making the decisions. We've kind of become a cog in the wheel where, minutes doing this and that are counted, and our input is not seen as a valuable use of our time in how to make the system. We, as physicians, we actually have a really unique position that we see patients from the start to the end of the journey. So like as a surgeon, I see someone come in with their arthritic hip. I see them before surgery, I do the surgery, I see them afterwards. All the other practitioners kind of have episodic care. And so we see that move through the system, and we see where the barriers are, where the inefficiencies are, and we're not really able to kind of influence change to make it more efficient. And that's, I think, where conversations need to happen, and conversations are cost-free.
Okay, thank you. Ms. MLA Morgan?
Thank you, Madam Chair. I have one more question. Brief note, too, on the 2020 Workforce Plan. I have attempted many times and through ATIP and through various channels to try to get a hold of this plan, and apparently it is one of the most top secret documents in this entire government, because it is, anyway, I have not been able to get a hold of this plan, but I will keep trying, because I think we all deserve to be able to see what physicians worked hard on trying to propose to us. Anyway, my final question though here is, in your list of asks, under funding healthcare frontline, there's a mention in C that you would like a halt to implementation of new initiatives with a focus of forced growth on the ones already in place. I wondered if you could explain more what you mean by that. Are you talking about like no new services, no new programs, or no new like rearrangements of primary care? Or can you just sort of explain what exactly are you asking for a halt to? Thank you, Madam Chair.
Dr. Mooney?
Yes, thank you for that question. Yes, primary care is one of the examples. Stop trying to rearrange primary care and focus on what we have and making it really good, and like actually funding the positions that we need for primary care as it is. Another example I can use is the new opening of the long-term care facility at Kliwagunti on the 3rd floor. Like, yes, palliative care and long-term care is something that we 100% should be providing. However, there's 2 units open now, and we can't staff 1 unit effectively. So I think part of this ask is stop adding more work to the people that already can't do the work we're expected to. So, you know, we have 2 long-term care homes open, and 1 nurse effectively responsible for 33 patients. Like, stop adding more patients to our plate and just focus on the ones we have and actually getting them the care that they need.
Okay. Amelie Yakalaya, do you have it? Oh, okay. Okay. So if we don't have any more other questions, then we will conclude. Amelie Morris, do you have?
No, it's fine.
Are you sure?
We could be at the salt day. Yeah, it's not questions, it's expressions, and I can see that.
Okay, okay. Okay, yes, then if there's no more other questions, then, you know, living in a small community, in NWT, it was a challenge already, and especially in small communities with high cost of living. And we know that we do need more physicians and nurses. And our goal for this assembly is to improve the healthcare in the NWT. So, and I'm very grateful, thankful to the presenters. There's a lot of good information shared that we were not aware of. Maybe Yellowknife MLA were aware of because of their constituents, but I know that we heard some of the issues in small communities from our constituents. So this is really good information for us. And our focus is to improve the healthcare in the NWT. So with that in mind, thank you for joining us, and this concludes the public briefing on healthcare sustainability and accountability in the NWT with Medical Association. So thank you for coming.